Hello friends, I'm Dr. Bharat Jagyasi, Director of Critical Care Department, Co Club and Hostel Navi Mumbai. I was General Secretary of ICCM last year, that is 2024-2025. Today we'll talk about diabetic emergencies in critical care. And to discuss the same, please allow me to share my slides. Just a moment, please. So when you talk about the diabetic emergencies, mainly we are talking about the hyperglycemic emergencies, that's DKA, diabetic ketoacidosis, HHS, that is hyperosmolar hyperglycemic state. Initially, it was called as hyperosmolar non-ketotic coma. That was an older name. So older terminology was used for decades, and it was stressed mainly on the hyperosmolarity, very high glucose, and absence of significant ketones. Coma, though it was labeled, but we had very few patients who really landed into the coma. We had majority of the patients were a little disoriented or agitated. So this is why the American Diabetic Association and the Joint British Diabetes Societies for the inpatient diabetic patients recommended a name as HHS, that is osmolar hyperglycemic state. The reason being is it's more accurate because many patients do not present in coma, and some patients do have mild ketosis as well, and focuses on overall syndrome, not just on the coma. So also we have mixed DKA and HHS and euglycemic diabetic ketoacidosis. We are seeing this more often because of the new anti-diabetic drugs. And then we have the next category, that is hypoglycemic emergencies, where we look into the severe symptomatic refractory hypoglycemic patients, mainly due to the sulfonylurea related. And also we'll have the metabolic complications like lactic acidosis, cerebral edema, dyskalemias, all we'll discuss in this talk. So we know the India is becoming kind of a diabetic capital across the globe, and we have the rising diabetic burden, which translates increased admission to the ICUs. And the delayed in diagnosis carries a substantial mortality risk, which is around 1 to 5% in DKA when diagnosed promptly. The mortality is relatively high, around 10 to 20%, especially in the HHS patient as compared to the DK. And when it comes to the mixed component, the patient with presence with the DK as well as the HHS, the mortality goes up to 30%. And there's also interaction with the sepsis, organ failure, corticosteroids, and SGLT2 inhibitors, which demand heightened clinical awareness. So when you differentiate between the DK and HHS, because it's very important to differentiate in between the two, because treatment modality and the monitoring modality varies a little bit. There's a slight tweak in between the two. So when there's a ketosis with acidosis, this defines the diabetic ketoacidosis. And with the severe hyperosmolarity without acidosis, that is very characteristic of HHS. And recognition of these patterns drives appropriate management pathways. So when you look into DK, the glucose is most probably more than 250, while in HHS it's more than 600. The pH would be low in the DK, less than 7.3, which would be approximately normal or more than 7.3. BICARB would be low, that is less than 18 in DK. It should be more than 18 in HHS. Ketones would be positive in DK. It could be minimal or absent in the HHS patient. The osmolarity, which is a major differentiating factor in the DK, would be the 290 to 320 milliosmol per kilogram, while it would be more than 320 milliosmol per kilogram in case of HHS. And the mental status, as we discussed, is mild or moderately impaired in case of DK, but is severely impaired in case of the HHS, not necessarily coma. And iron gap, of course, would be elevated in the DK. It could be normal or slightly elevated in the HHS. And we talk of the mixed syndrome, which is very important because the mortality is pretty high, as we discussed, around 20 to 30% the mixed syndromes. So it is very characteristic of dual pathology. It has the both components, that is severe acidosis of the DK and the marked hyperosmolarity of the HHS. So whenever there's an acidosis along with the hyperosmolarity, we call it as a mixed DKA HHS syndrome. Both have been presenting simultaneously, and we need to be really worried about this because the mortality in such cases is pretty high, and it requires a complex management because very slow correction of the osmolality while maintaining the DKA level infusion rates of the insulin, which is very difficult to achieve a balance. So it's very important to recognize this because they carry a substantially elevated mortality risk and demand particularly careful metabolic monitoring throughout the treatment. So now let's understand about the pathophysiology. So when you talk of the diabetic ketoacidosis pathophysiology, there's an insulin deficiency. It could be the absolute or the relative, which triggers the cascade. And there's a counter-regulatory surge of the catecholamines, cortisol or glucagon elevation, which leads to the lipolysis activation. So more of the free fatty acids are released, and hepatic ketogenesis also comes in play. This is the reason why the dominant ketone body drives acidosis, that is most commonly is the beta hydroxybutyrate. And because of this, there's a volume depletion, that there's an osmotic diuresis, there's a loss of the potassium from the body, and this is how the DKA pathophysiology comes in play. When you talk about the HHS, the relative insulin deficiency. Insulin deficiency is less as compared to the DK, and as a result, it is adequate enough to suppress the ketogenesis, but yet insufficient for the glucose control. And this is why the severe hyperglycemia perpetuates profound osmotic diuresis, and the critical consequences are water loss, excess sodium loss, producing marked hyperosmolarity, and the fluid deficit almost reaches 8 to 12 liters, with substantially elevated risk of the thrombosis. So how do we diagnose it? As we looked into it, we need to do VBGs or ABGs for the looking at the acidosis and the pH, bicarbonate assessment. We also look into the serum ketones and the urinary ketones, particularly the latest guidelines demonstrate or let us know we have treatment needs to be targeted as per the serum ketones level. And the most commonly what we monitor is the serum beta hydroxybutyrate, which is superior to the urine ketones. Electrolytes, the sodium, because it will decide which fluid to give, and the potassium, which is a major deficient in the potassium levels. In spite of showing the high potassium level, we need to monitor it, and our insulin treatment depends on the potassium levels. Also, we need to monitor about the chloride. Osmolality, we need to measure this, as it will a very important factor which will help me diagnose in differentiating between the ketoacidosis, that is DKA, diabetic ketoacidosis, and the HHS, that is hyperosmolar hyperglycemic state, or it could be the mixed disease as well. So just remember this formula. And additional tests to look about the renal function, lactate, and anion gap calculation, because these are the very good prognostic markers, and also will help us. The trajectory of these things will let us know whether the patient's improving or not, whether our treatment is effective or not. So fluid management, which is very important in case of the hyperglycemic diabetic emergencies. So when you talk of the DK, the initial first hour is the 0.9% of the normal saline. Around 1 to 1.5 liters of bolus should be given for the hemodynamic stabilization. Then the step 2 would be to look for the corrected sodium to guide the subsequent fluid choice. If the corrected sodium are high or normal, then we go ahead with the half, that is 0.45% saline. If the corrected sodium is low, then we can still continue with the 0.9% of the saline, and the maintenance rate is somewhere around 250 to 500 ml per hour, which needs to be adjusted for the age, the cardiac comorbidity, and the renal status of the patient. So eventually what we look into is, we look into the target restoration of around 50% of the fluid deficit within 12 hours, while avoiding rapid osmolarity decline to prevent the cerebral edema. When to add dextrose, this is very important, and the timing is very critical, because we have to have insulin ongoing, because insulin is a major thing which corrects the ketone clearance. So if we don't add dextrose to it, there will be the incidences of hypoglycemia, and we might have to stop the insulin, and our ketone clearance will get delayed. So whenever the glucose reaches around 200 milligram per deciliter, switch to the D5 or the DNS kind of DNS kind of a fluid where there's a dextrose in it, and the rate should go on at around 150 to 250 ml per hour, or we can have the separate D5 and the 0.5% or the 0.9% of the saline as per the corrected sodium, and continue insulin infusion to clear anion gap and resolve acidosis. And dextrose is mainly to prevent the hypoglycemia, while we have to continue the insulin delivery for the ketone clearance. So resolution, the critical principle is resolution requires normalization of pH, bicarbonate, and anion gap. It's not just merely a glucose correction. So emerging few strategies, we can use the balanced crystalloids, that is lactated ringers, or the plasma light reduce. We all know reduce hypercolemic acidosis. We have come across SMART and SALTED trials which have given insight on the support of the balanced crystalloid consideration, especially in the patient where the where the loss of fluid needs to be infused, and which is true in both these cases. So it will lead to the hypercolemic acidosis, which could be the disaster. So we can continue with the balanced crystalloids after the initial bolus of the normal saline. And the paramount principle is to avoid osmotic correction as exceeding 2 to 3 milliosmol per kilogram per hour. With the use of the balanced salt solution, the post-hoc analysis suggested accelerated DKA resolution time, and the pragmatic approach could be, I use initial normal saline, which is acceptable to everyone. Then for the maintenance, we can switch to the balanced salt solutions. Insulin therapy also forms an integral part of the overall management. So the dose selection is important. We can continue using zero point 0.1 unit per kilogram per hour infusion with optional, or I can use zero point 0.1 unit per kilogram bolus and then followed by the infusion. Both are equally effective. What I have to look into the targeted decline in the glucose. It should be somewhere around 50 to 70 milligram per deciliter per hour, which ensures controlled correction, and the faster correction will lead to the faster correction of the osmolality, which is very critical to prevent the cerebral edema. So we have to avoid the faster corrections. We have to have a control correction of the glucose if we don't want to land up into the further complication of DKA and HHS. Potassium prerequisite, we never commence insulin unless the potassium is more than 3.3 milliequivalent per liter to prevent life-threatening hypokalemia. We'll come on this, we'll discuss the reason of this in the further course of this discussion. So DKA resolution, as we discussed, is not only about the glucose control. What we are also looking into the anion gap closure that is getting normalized. Bicarbonate is getting more than 18 milliequivalent per liter, and the pH, that is venous pH, is more than 7.3. So all four criteria must be met before transitioning to the subcutaneous insulin. Premature discontinuation of the IV insulin risk rebound ketoacidosis. Potassium algorithm. So total potassium deficit is around 3 to 5 milliequivalent per kilogram, despite potentially normal or elevated initial serum levels. And what happens is, moment you start with the insulin drives in intracellular potassium shift, which risks profound hypokalemia and further cardiac arrhythmia without adequate replacement. So this is the chart what we follow. If the potassium is more than 5.3 milliequivalent per liter, do not replace potassium, monitor hourly. If it's somewhere in between 3.3 to 5.3, then add 20 to 30 milliequivalent to each liter of IV fluid. The potassium is less than 3.3, hold insulin immediately. Correct potassium the moment is more than 3.3, then restart your insulin infusions. We also come across the additional electrolyte abnormalities, which are very important to consider in this scenario. The phosphate is very dangerous because the hypophosphatemia would lead to the arrhythmias, which are compounded by the hypokalemia as well. So replace only if that is less than 1 milligram per deciliter, or if we encounter there's a respiratory failure as well. Magnesium needs to be maintained more than 2.0 milligram per deciliter to optimize insulin sensitivity and the cellular function. Bicarbonate, when to give, it's very controversial. We reserve when the pH is less than 6.9 or 7.0, and 100 millimole in 400 ml plus KCl should be given over a period of 2 hours. HHS, we need to talk about this. So basically, as we understood the pathophysiology, there's a massive fluid deficit over here, approximately around 8 to 12 liters of the deficit, which requires aggressive fluid correction, resuscitation with 0.9% of the normal saline initially. Then we can switch over either to the 0.45% normal saline based on the corrected sodium, or maybe the balanced salt solutions. Here, the insulin dose is lower, almost half the DKA rate with the target glucose maintenance, as discussed. Because we have to have controlled correction of the osmolality, we cannot correct it fast. The moment we correct the osmolality over here fast, we might come across the dreaded complication of the HSS, that is the cerebral edema. So osmolality reduction needs to be less than 2 to 3 milliosmol per kilogram per hour to prevent the neurological complication. Because there's too much of the fluid loss over here, the whole system is hyperviscous, so there's a very high chances of the thrombosis, and this is why the DVT prophylaxis should be initiated given the marked thrombosis from hyperviscosity. Euglycaemic DKA, this is a hidden trait, and it's more commonly seen because of the SGLT2 inhibitors, which is a newer anti-diabetic drugs being in use and very commonly being used these days. Also, it could be seen in the pregnancy, prolonged starvation, patient who's been a chronic alcoholic and had binge of the alcohol, and the perioperative state because of the fasting state. The key features here are the glucose is somewhere around 100 to 200 milligram per deciliter. We all feel maybe it's normal or minimally elevated, but the ketosis and acidosis remain severe despite euglycemia. So the clinical pearl is, whenever we have the ketosis and the acidosis, in spite of sugar being normal, or that is glucose being normal, always have high index of suspicions and check for ketones in all acidotic patients regardless of the glucose levels. So how do we treat this? So immediate actions would be to stop SGLT2 inhibitors immediately, identify and treat precipitating factors like infection, vomiting, fasting state. Here we need to start dextrose early because, as we understood, insulin is very important for the ketogenesis to clear the ketoacidosis. So because the glucose is over here normal, to start with the insulin, I need to have the dextrose on. So we can commence with D5 or D10 infusion early, unlike the standard DKA protocol because the glucose is already low. And the full DKA insulin rate has to commence on, which often requires higher doses due to severe insulin resistance. And here we need to monitor very aggressively, especially for the glucose and the ketone checks and the balanced insulin dose against dextrose infusion rates. Now we come to the severe hypoglycemic emergency management. So we define it hypoglycemia when glucose is less than 54 milligram per deciliter with altered mental status, seizures, or loss of consciousness. The treatment is immediate infusion of 25 gram of dextrose IV, that is 25 ml of D50 or 50 ml of D25, administered as a rapid bolus dose, then follow with a continuous infusion of the D10. If there's a refractory case, especially in case of the sulfonylurea medication, then add octreotide, that is 50 to 100 micrograms subcutaneously or IV every 6 hours for refractory or recurrent hypoglycemia. So how do we monitor hypoglycemia over here? Moment we come across the patient with the sugars are less than 54 and there was a loss of consciousness or the seizures, we infused D25 or D50 in those patients. Check the next sugar immediately, frequently, until we have the sugar SGT more than 100 milligram per deciliter, the patient is stable. Then once we have the SGT more than 100 milligram per deciliter, we can extend our monitoring to every 30 to 60 minutes for next 4 hours and continue the maintenance dose of D10 throughout the monitoring period. Be very careful, be vigilant, because rebound hypoglycemias are common and can be more dangerous, especially with long-acting sulfonylureas. Avoid overcorrection causing hyperglycemia, which triggers insulin release and then subsequent hypoglycemia rebound as well. Cerebral edema is, as discussed, is very dreaded complication of the hyperglycemic crisis, especially when corrected immediately. So it's very important to recognize and manage it. It's more common when in young patients, especially when the age is less than 25 years, particularly children, when there's a markedly elevated osmolality at presentation, and we end up with the rapid osmolality correction and or the biocarb administration. So what are the warning signs? There could be the severe headache, altered consciousness progression, that is the GCS will further go down. We might come across the Cushing's reflect as the bradycardia or the hypertension because of raised ICP. There could be the pupillary changes and the posturing as well. There could be the extensor responses when we are looking into the reflexes. So how do we treat it? Reduce fluid infusion rate immediately, because we have to have controlled osmolality correction. Can give mannitol 0.5 to 1 gram per kilogram IV or 3% of hypertonic saline. I'll always follow the 3-tier pattern of the ICP management, that is elevate head of bed around 30 degrees, frequent neurological assessment, and imaging after stabilization to look for other causes. ICU monitoring indices. So whenever we come across these in hyperglycemic crisis patients, so metabolic indices which need to be frequently monitored are the beta hydroxybutyrate clearance rate, that is superior ketone marker as compared to the urinary ketones. Calculate osmolality very frequently. We don't want to overcorrect it. Look into the corrected sodium trending to decide which fluid needs to be given. Also look for the anion gap closure monitoring that will guide you whether our treatment is effective or not, and also the delta gap assessment and lactate clearance trends. Hemodynamic indices to look for the fluid management. We can do the shock index, that is the heart rate and the ratio of the heart rate to the systolic blood pressure, the velocity time integral via echocardiography. We can look into the IVC collapsibility assessment or the dynamic assessment indices like PPV or SVV. We can also look into the extravascular lung water available, especially in the cases of the cardiac disease or the chronic renal failure, where there are more chances of patient getting overloaded and pulmonary edema. Special situations, especially in the pregnancy-associated DKA. So lower diagnostic threshold DKA can occur when the glucose is less than 200 milligram per deciliter. Maintain glucose somewhere around 140 to 160 during treatment, and the fetal monitoring is also essential. Subset trigger crisis, initiate antibiotics early. Volume deficit could be more than the calculated one, and there's a marked insulin resistance, requires higher insulin infusion rates, which is very common in the infections. Acute kidney injury, fluid management needs to be more conservative. potassium replacement, we need to be very cautious and consider renal replacement therapy early if the severe DKA we face across. So these are the evidence-based updates what I spoke about, and the American Diabetic Association 2024 recommends blood ketone guided management protocols now standard recommendation. Fluid trials, as we spoke about, the SMART trials implicates favored more towards the balanced crystalloids, maybe after the initial resuscitation. And the SGLT2 inhibitors guidelines updated euglycemic DKA recognition and the management strategies, as we have spoken about. Technology, we can look into the continuous ketone monitoring migration to the clinical practice. And the key takeaways is very important, especially in the hyperglycemic crisis. We need to differentiate between the DKA and HHS or the mixed presentation. Fluids are the first priority. Aggressive fluid resuscitation, precise insulin, check potassium before insulin commencement. Timing on the dextrose is very important. Add D5 or D10 when the glucose is somewhere around 200 milligram per deciliter for the DK, and maybe 250 to 300 milligram deciliter for the HHS patient, and continue insulin for the ketone clearance. In case of the euglycemic diabetic ketoacidosis, requires early dextrose despite normal glucose. Maintain standard insulin rate as was for the DK for the with the early dextrose infusion. Hypoglycemic vigilance is very important. Check sugar very frequently, maybe every 15 minutes until stable. May need octreotide, especially in the case which are resistant because of sulfonylureas. Avoid rapid correction of the osmolality. It should not be, osmolality reduction should be less than 2 to 3 milliosmol per kilogram per hour. It prevents cerebral edema and saves lives. Thank you very much. Kindly log into my YouTube channel, subscribe, and also share with your colleagues and friends to spread the knowledge. Thank you very much.